Hi everyone, this is Tim, your Block 1 lecture instructor, and today we're going to cover chapter 34, which is skin integrity and wound healing. I will forewarn you, this PowerPoint is about 70 slides long, so definitely take some breaks. I'm going to kind of breeze through a lot of stuff. I think for this lecture it's going to be more about showing you what the different wounds are and describing them than it is to actually show you in PowerPoint. So I'll cover some slides that I think that are important, and like I said, we'll kind of breeze through the rest of them and we'll cover everything else in class. So for the learning outcomes, we have discussed the factors that affect skin integrity. We have identified wounds based on accepted classification schemes. We have described the 3 phases of wound healing. We have distinguished primary intention healing, secondary intention healing, and tertiary intention healing. We have described 3 types of wound drainage. We have reviewed the major complications of wound healing, explain the factors involved in the development of pressure ulcers, use the Braden scale to assess risk for pressure ulcers, assess and categorize pressure ulcers based on the pressure ulcer staging system, provide nursing care that limits the risk of pressure ulcer development, differentiate the kinds of chronic wounds, accurately chart assessment of a wound, demonstrate appropriate technique for irrigating a wound. And we also have described care of a wound with a drain, differentiate the 5 forms of wound debridement, discuss the different kinds of tissue found in wounds, discuss when and how to use absorbent, alginate, collagen, gauze dressings, transparent films, hydrocolloids, hydrogels, and foam, and antibacterial dressings. And finally, we have described guidelines to follow when applying heat and cold therapy and demonstrate bandage and binder application. And so there's a lot. So the next slide, we have structure of the skin, which is epidermis, dermis, and subcutaneous layer. All right, so factors affecting skin integrity. I want you to be more familiar with these as I find that they're important, and I'll kind of go over them. So the first one, we have age. We have older adult skin. It's less elastic, it's drier, it has reduced collagen and areas of hyperpigmentation and more prone to injury. Let's see here, for older skin, it has been exposed to a lot. So we've got sun, we've got chemicals, and again, we've got loss of collagen. For mobility status, increased pressure, shearing, and friction can lead to breakdown. For mobility, it's the inability to move or for patients who are complete bed rest, and this also causes skin breakdown. So for nutrition and hydration, we've got protein, which is needed to maintain and promote healing, maintains skin and repairs defects, and also preserves extracellular volume. So for nutrition and hydration, we've got poor nutrition, less regeneration, and for dehydration, it equals poor turgor. We also have cholesterol, which low levels can cause skin breakdown. For calorie intake, needs for protein to prevent weight loss, loss of subcutaneous tissue, and muscle atrophy. So for calorie intake, and again, cholesterol and protein, I think all of this not only helps prevent breakdown, but also whatever breakdown you do have, it'll actually help build and allow the wound healing to heal faster. And then we have ascorbic acid. This is oftentimes when you have a patient who has pressure ulcers or some sort of incision, the doctor will order vitamin C. The body needs vitamin C for collagen maintenance and promote wound healing. And again, we have hydration, which improves skin turgor. So for sensation, we've got diminished sensation leads to increased risk for pressure and breakdown. One thing that kind of came to mind when I was doing this was that I think for sensation, I think a perfect example would be a diabetic foot ulcer. Diabetics tend to have peripheral neuropathy, so they don't feel real well in their lower extremities. So whether they're, they should never go barefoot. Just because they could be stepping on something and not know that they have. It could be a splinter, glass, etc. And by the time they actually do realize that it's there, it's caused some sort of wound, and because of the vascular problem with diabetics, especially in their lower extremities, it tends to get bigger and take longer to heal and becomes more of a problem. So according to this, diminished sensation leads to increased risk for pressure and breakdown. You have the older adults. Again, we talked about the bucket. You know, they're laying in bed, their heads kind of semi-fowlers, and their legs are up, and they kind of their butt sits in this bucket. Um, that bucket will cause pressure on their skin, and because they have poor circulation anyways, it causes the breakdown to even be better. So let's see here. We have impaired circulation. Again, we'd mentioned the bucket. We talked about the older adults, even the diabetics. Um, with impaired circulation, poor circulation delays wound healing, poor arterial circulation, which will cause ischemia and necrosis, and then poor venous circulation causes edema, ulceration, and again breakdown. So medications, we have side effects, which could cause itching and rashes. The medications that or the examples they had given in your book was blood pressure medications. If it lowers the blood pressure, the circulatory system has slowed down, so the certain areas won't get as much blood flow. We have anti-inflammatories. Again, this will actually cause shrinking, and with shrinking and low blood volume and circulation, it kind of promotes more wounds than it does preventing. We have anticoagulants that will usually cause bleeding and bruising. We have chemotherapy. Chemotherapy, in my mind, is designed to kill off everything. So if it's killing off all the bad stuff, whether it be cancer and cancer-like diseases, it will also kill off good stuff. So white blood cells, lymphocytes, phagocytes, things that will actually promote healing. Antibiotics will also cause it. I also think of prednisone. Prednisone is also an anti-inflammatory, usually given, or it's actually a steroid, but used as an anti-inflammatory, and is usually given for patients who have upper respiratory problems, COPD, or other swelling in the body. That prednisone as a side effect will cause skin to be very thin and like tissue paper. So the patients who are like that will tend to break down and also tear very easily. And then sometimes herbal products will cause breakdown also. So let's see here, we have moisture, and let's see here, with moisture comes maceration. Maceration is moisture causing softening of the skin. Patients who are at risk are those who are incontinent or who have fevers. Patients who are incontinent of bladder and bowel, both urine and feces is very acidic. That acid will actually break down skin very fast. Fevers will tend to cause maceration just based on, if you've got a 103 temp and all of a sudden you break it, you just break out into the sweat. So the moisture from that is what causes the actual maceration. Fever also depletes the moisture, will make people dehydrated, and it also increases metabolic rate. So sweating causes maceration. Maceration increases oxygen demand, which also causes circulatory impairment, which then leads to tissue compression. So pay some special attention to that section of your book. It's pretty important. We also have infection. Infection impedes healing. Again, your body's trying to fight off too many things at once, and something's got to give, and usually it's the wounds. For lifestyle, we have tanning, bathing, piercings, tattoos. The book also mentions hygiene and smoking. I think hygiene is a really, really big, important part of wounds. You'll have normal walkie-talkie patients that come in and they've got some sort of small minor wound. That has turned into something major, and it's as simple as just keeping things clean. Bathing regularly, using ointments or cleansers that actually keep things clean, and they just don't do it. And so again, lifestyle is, I think, the big part, and it doesn't have to be somebody who's just dirty or homeless or not taking care of themselves. It's really just not taking good care of that wound at the beginning and keeping it clean, and then it turns into something worse. All right, so for clicker check, of the following factors, which would put a client at greatest risk for impaired skin integrity? We have medication digoxin, we have moisture, decreased sensation, or dehydration. And the answer is C. Decrease in sensation would greatly increase the risk for injury with a tear or break in the skin. This could lead to a delay in seeking treatment due to the lack of awareness. Again, remember your diabetic patient with the foot problem. So next we have classification of wounds. We have open and closed. We have acute chronic. We have clean, contaminated, and infected. We have superficial, partial, or full thickness, and we have penetrating. So with closed wounds, I think of them as being bruises. So the skin actually isn't broken. We have open, which is an actual break in the skin. We also have acute, which is a short duration of a wound. And then we have chronic, which is more of the patients who have not only broke down and got some sort of decubitus ulcer, but it's gone very deep, and it's going to take several months, and possibly I've seen people with years of time need to take to heal. So as far as clean wounds, we've got uninfected wounds. So basically, let's say you scratch yourself and you need to come to the emergency room and you need to get stitches. It's uninfected. It's you've got the proper care at the right time, and they were able to suture it, and you keep it clean. We have clean contaminated, which is an actual surgical incision involving the GI tract, respiratory area, and we have also genitourinary. So they're clean, but because of where they are is what causes them to be contaminated. Contaminated wounds themselves are traumatic wounds, surgical wounds, and they usually involve a break and a sepsis. So you're going to have patients who are going to have surgery that may not be under the greatest of conditions, and those wounds will tend to get contaminated, and they will delay their discharge or delay their wound healing, because they're going to have to be put on a lot of antibiotics and try to get rid of the infection and also try to heal. And let's see here. Infected wounds are usually wounds with bacteria, whether it be MRSA, VRE, and everything else. So let's see here. We have superficial wounds, which is the epidural layer. We have partial, which is the epidermis to the dermis, and then we have full thickness, which is the subcutaneous and or deeper. And then we have penetrating, which actually may go all the way to organs. So we have type of drainage. We have serous exudate, which is straw-colored. We have sanguinous, which is bloody drainage. We have serosanguinous, which is mix of bloody and straw-colored fluid. You'll see more serosanguinous fluids from patients that have had some sort of surgery, especially abdominal surgery. And it really is kind of a mixture of body fluid and also blood, so it kind of mixes and it dissolves, and it does have like a I don't know, let's say probably darker pink, but not like a bloody color. And then you have purulent, which is yellow, and that's, I mean, you can tell that it's infected and it's very pussy. So wound healing processes, we have regeneration, which is obviously for the epidermal wounds to actually heal with no scar. We have primary intention, which is a clean surgical incision as edges are approximated with minimal scarring. We have secondary intention, which is wound edges are not approximated, it has tissue loss, and it heals from the inner layer to the surface. So let's look at the elderly patient who is not only broke down but actually got a decubitus ulcer. This would be a secondary intention. They tend to have the edges are they're not approximated in the sense that it's not a specific or a perfect round shape. You definitely see it's almost as if someone really just took like a bandage and ripped it off, and they ripped off the skin. Everything is just kind of lot of sorts. But along with that, it comes tissue loss. So when they actually have to go in and do some sort of surgical intervention to get it to heal, they have to go in and actually cut out all the dead tissue, and then and either they'll put a wound vac on it, which will actually help suck out all the infected fluid, but it also allows wounds don't just heal from side to side and meet in the middle. They actually will heal from the bottom up. And we'll go over that in class a little bit more. So if tertiary intervention or intention is granulating tissue brought together, this is instead of um, the secondary being, as I said before, instead of actually healing from the bottom up, the actual tertiary is sutured together and then they actually grow and regenerate. So complications of wound healing, we have hemorrhage, we have infection, dehisced, which is an example of the top picture. We have evisceration and fistula formation. Fistula formation is the second picture. That's actually not uncommon with abdominal surgeries that, especially with heavier people, the sutures just don't aren't able to keep that incision together, and then as it busts open, things fall out. So clicker check. A client calls the nurse to the room and states, "Look, my incision is popping open and where they did my hip surgery." The nurse notes that the wound edges have separated 1 centimeter at the center and there is straw-colored fluid leaking from one end. The nurse's best action is to notify the surgeon stat, place a clean, sterile 4x4 over the incision and monitor the drainage, wrap an ACE bandage film around the area and have the client maintain bed rest, immediately cover the wound with sterile towels soaked in normal saline and call the surgeon. Your answer is going to be B. A 1 centimeter separation of wound edges only in the center of a surgical incision on the hip is too small to truly be determined dehiscence. Even if there were a large separation, there are no internal viscera to protrude. Just to kind of review some of these answers, the wrapping ACE bandage firmly around the area, that's wrong only because you're in a cough circulation. Notifying the surgeon stat, you don't necessarily call a doctor stat unless there's either a large amount of blood loss or your patient's blue. And then as far as immediately cover the wound with sterile towels soaked in normal saline and call the surgeon, I mean, that's too excessive. So that's why answer is B. So nursing assessment, skin and wounds. Focused skin assessment. You're going to do a Braden scale, which is based on sensory perception, moisture, activity, mobility, nutrition, friction or shear. The Braden scale is what we use in the hospital on every patient. It does determine whether or not they're actually at risk for breakdown. The numeric value for 6 risk factors related to impairment in skin integrity and a total score of less than 18 is this risk. So I'd probably be familiar with that scale. Alright, so you're also going to do a wound assessment. You're going to check for location, size, appearance, drainage, redness, and swelling. See here, there's 2, 4, 6 areas. Those 6 areas are very important when you do your charting. Not only do you want to know where it is and the size, because the size could get bigger, or if it's healing, you want to see if it gets smaller. You want to describe the appearance, because at one point it may look like something one day and the next day it may actually look worse, or it may get better. And as far as the drainage, as a wound heals, the drainage not only become less, but the actual drainage itself looks different. You also have redness. If it's pink, that's normal. If it starts to get red or starts to swell, that's a big sign of an infection. All right, so initial interventions related to wound care. You're going to do cleansing and irrigation. You're going to care for a drainage device. So the picture is actually a Jackson Pratt. When it's opened, it looks like a grenade. And then when you actually go to suck the stuff, what's in them out, you're going to compress the bulb, put the stopper on it, so that way it actually pulls it out based on suction. A hemovac is usually a machine that looks like a wound vac that is continuously sucking out the drainage. You'll have a debriding of a wound. In the hospital, we call it an IND, which is an incision in debridement. Usually is an incision that they make based on a scalpel. It's usually them cutting into it, cutting out the dead stuff, and actually either suturing it back up or placing a dressing over it. So that's pretty much it for the IND. Applying negative pressure on wound therapy. Where I work, we actually have something called HBO, which is hyperbarics, that usually tends to help, which is also a negative pressure. For dressing on wounds, you'll usually use gauze and transparent film. The hydrocolloids and the hydrogels. Usually this is you placing the hydrocolloids or the hydrogels on the wound, and then you'll usually put gauze over top of it, and then a transparent film, or you'll put gauze over it and then you'll put tape on top of that. We have supporting and immobilizing a wound. We've got binders and bandages. We will also apply heat and cold. So for a wound for a special consideration, we've got the pressure ulcer. Nurses play a major role in prevention and treatment. Pressure ulcers affect 15% of the hospitalized clients or patients. They're caused by unrelieved pressure to an area, resulting in ischemia. Again, you have that 80-year-old patient that's sitting in that bucket of the bed. It's not getting enough circulation because it's almost like, and it sounds kind of stupid, but it's almost like sitting in a movie theater seat. And you sat there for like 2.5 hours and you didn't really move and you kind of get up and your butt's numb. That's the exact same thing when I describe it as the patient being the bucket and losing circulation. If they lay there long enough, I mean, we only sat there for a couple hours and we're healthy people and lost feeling. If you're 80 years old and you've laid in the bed for 12 hours and didn't rotate, that's going to break down. Risk factor for pressure ulcers and developments, also an intrinsic factor, immobility, impaired sensation, malnourishment, aging, and fever. Again, with the immobility, they're laying in bed and they're not moving. Impaired sensation, we're looking at diabetic patients with peripheral neuropathy. We're looking at paraplegics, quadriplegics, people who don't have the ability to tell whether or not their butt has gotten numb and to shift their body weight and to move themselves. So we've also had malnourishment. Again, you need protein in order to prevent breakdown and also to promote healing. The aging, again, you're looking at the 70s, 80s, 90-year-old patients that just can't move real well. And then we have also fever. They break that fever, they start to sweat. Extrinsic factors will be friction. That's lifting the patient up in bed, and instead of actually physically lifting them up and shifting them in bed, you're pulling them up in bed, and that actually causes friction on their skin. Pressure, again, the shearing and exposure to moisture, which could possibly be fevers, or even if they're incontinent. If you're not cleaning them properly or as fast as you can to keep their skin from coming in contact with the acidic urine and bowels, then that will also break it down. So nursing assessments for the pressure ulcer determine stage. We have stages 1 through 4. They're classified by tissue involvement. Stages 3 and 4 involve tissue necrosis, and then also suspected deep tissue injury. And familiarize yourself with the push tool. So clicker check. The patient has a wound that is 0.4 centimeters long and 3.2 centimeters wide. There's only a light amount of exudate and granulation tissue. The push score for this would be, and the answer is going to be A, points. So you got 2 length, 6th width, which is 12. And you have exudate, which is 1, and granulation, which is 2. So interventions for the pressure ulcer. You've got prevention. Prevention obviously is going to be the key. You want to rotate your patient every couple hours, get them off their butt, use pillows, prop them up, get them in a chair, get them walking. Do whatever you can to, the biggest disservice we can do for our patients is allowing them to just stay in bed. If you can walk, you should be at least sitting. If you can only walk short distances, let them walk to the bathroom with help. But try to get them out of bed as much as you possibly can. Even if they're getting out of bed for just their meals, it's better than laying in bed for 12 hours. Adequate nutrition, again, push the proteins, push the glucernas and the protein drinks. We have protein shakes. I mean, there's a million things that we have at the hospital that has high amounts of protein in it, because that's what's going to, prevent or promote the wound healing. Frequent repositioning. Again, we have a lift team at where I work where they come by and they actually rotate your patient every 2 hours. Therapeutic mattresses. We've got air mattresses. We've got the mattresses with the egg crates. We've also got the other beds with the sand in them. Those tend to all those beds tend to rotate their body a little bit more so that they're not just laying on a bony promise, whether it be their coccyx or their hips, their knees, their heels touching the bed. You know, the more we prop them up and the more we rotate, the less those areas are going to break down even further. All right, so at this point, you're going to go to page 825 in your Volume 2 book. Look that over and we'll talk about it in class. All right, so pyodermis, we got impetigo, which is a superficial infection of the skin caused by streptococci and multiple bacteria. We have folliculitis, which is an infection of bacterial or fungal origin arising from the hair follicle. We tend to usually find these in young women who have, how do I put this, shaved their vaginal region, and usually it's more ingrown hairs than anything else. We have carbuncles, which is an abscess of the skin and subcutaneous tissue. We have dermatitis, which is contact dermatitis, inflammatory reaction of the skin to physical, chemical, or biological agents. So basically, your skin comes in contact with something and it gets red and inflamed. We have non-infectious inflammatory dermatosis, which is psoriasis or exfoliate dermatitis. We have cellulitis. This is probably the biggest patient you'll see in the hospital as far as skin conditions. It could be anywhere from, walkie-talkie 20-year-olds to your 90-year-old grandma. Basically, you bump into something, it either breaks the skin or causes the actual cells of that area to become inflamed. It allows bacteria to enter, and then what you have to do is go on IV antibiotics in order to get rid of it. They tend to give you orals for about a week or so to see how well it does, but my experience has been after that's run out, they come to the hospital and they need their IV antibiotics. This also can be a systemic reaction of fever, chills, and sweating. Treatments include oral and IV antibiotic therapy. Nursing management is elevate affected areas, apply warm, moist packs, and educate on the prevention of reoccurrence. Besides the IV antibiotic therapy, usually we do elevate their extremities. You can apply warm, moist packs, but we tend to usually do ice packs. And then obviously the education prevention, because if they've done it once, they could possibly do it again. So we also have fungal mycotic infections. This could be Tinea pedis, which is athlete's foot, Tinea corpus, which is ringworm of the body. We have Tinea capitis, which is ringworm of the scalp, and Tinea crisis, which is ringworm of the groin. So parasitic skin infestations, we have pediculosis, which is lice. We have head lice, and we also have pubic lice. We have scabies, which is an infestation of an itch mite. We've had scabies at the hospital before, and if you see them, you'll know it. So for this portion, which is also contributing to wounds, we have venous insufficiency. Venous abnormalities exist over 27% of the U.S. population. 2% result in ulceration. 70 to 80% are usually the lower extremities, and they'll involve the venous insufficiency as a major component. Venous ulcers have a recurrence rate up to 70%. Usually it's for patients who don't have good venous flow, and then things will break down and then it's hard for them to heal. So cost of venous ulcers, we have annual healthcare cost of $750 million to $1 billion. Average cost per ulcer is $2,000. That's $10,000. Quality of life issues and lost work days. So for venous function, in the upright position, blood returning to the heart from the lower extremities must battle gravity. So again, gravity is the key. Heart pumps out the blood, it goes all the way through the body, and the furthest part of the body is the feet. If you have either venous problems, which will include diabetic patients, because their blood being thicker, it's hard for it to move back up. And if you already have problems with that, then blood tends to pool, and that's where you get the ulcers. Again, here's the one-way semi-lunar valve, so every vein has a valve so blood doesn't backflow. And if they're not working correctly, blood does back up and it pools, and that's what causes the ulcers. Let's see here. Is any ulcer on the lower extremity a venous ulcer? And the answer is going to be, well, no. So the potential causes of leg ulcers can be venous insufficiency, arterial insufficiency, diabetic neuropathy, pressure, and sickle cell anemia. We also have rheumatoid arthritis. We have systemic lupus, squamous cell or basal cell carcinoma. We got malignant melanoma, pyoderma gangrenosum, which is basically gangrene. Chronic venous insufficiency complications for venous ulcers. They're usually over medial or anterior ankles, superficial, pink in color. Skin has a brown discoloration, cyanotic look to it. Normal skin temperature, but usually edematous, mild aching pain, and normal pulses. Arterial ulcers are usually over the toes, feet, and shins. Ulcer is deep and pale. Skin is pale when elevated but red when walking. Skin is usually cool to the touch, and there is little to no edema. Pain is severe and constant, may get infected, and pulses are decreased or absent. I want you to know this slide and know the difference between the venous and arterial ulcers. Diabetic ulcers. That looks like a heel, I believe. And that looks like the same heel that actually had packing in it. And they use the packing to help use that ribbon to help wick away and the pus and the drainage. That also looks like a diabetic foot ulcer. That looks like a diabetic foot ulcer that probably got worse, and then they actually had to cut the dead skin out, and they're trying to wait for it to heal from the inside out. Same thing, but this one looks like it's probably a diabetic who lost their big toe. All right, so we've got melanoma. And there's melanoma. More melanoma. Looks like more melanoma with a dirty finger touching it. All right, so critical thinking. Review the case of William Harmon. Meet your patient. What risk, if any, does William have for skin breakdown or delayed healing? What additional information do you need to know to fully evaluate his risk? And what risk do you have for impaired skin integrity? What actions can you take to protect your skin? So I do apologize for actually running through this quickly, but I wanted to get through all the slides. And again, I think if I show you more pictures and we do more discussion on patient scenarios and what to do and what not to do, I think you'll have a better understanding of it. Also, I am trying to get over a chest cold, so I apologize for the clearing my throat constantly. So anyways, write down whatever questions you have and we will go over them in class. Thank you very much.